Good morning, everyone. Thank you so much for joining us. I am Jessica Shortall at the R Street Institute and Coalition Manager building our Safer from Harm coalition. So Safer from Harm is a new coalition focused on amplifying the work of organizations and communities across the country that are working in harm reduction across myriad issue areas. Helping make that case for approaching public policy and public health across issues. You can learn more about Safer from Harm, subscribe for updates, learn about joining our coalition at saferfromharm.org. We'd love to have you. And I'll ask our panelists as we go to share their organizations as well. We'll tell you a little bit about them too, so you can learn more about their incredible and important work. Just a little housekeeping, please drop questions by clicking Q&A at the bottom of your screen. You can also go in there and upvote other people's questions, comment on questions, and we will get to as many as we can at the end. We got a lot to cover, so we'll see how we go there. So we'll just dive right in. I am really honored to be able to be here to moderate this discussion with a group of really committed, smart, compassionate, pragmatic harm reduction practitioners and experts from around the country. I'll tell you a little bit about them in the interest of time. So we have Angela Mallett, who's a mother activist, harm reductionist. She's also the VP of Operations for the drug policy reform organization End It for Good in Mississippi. And she lives with her daughter, Stella, who I've met virtually and is lovely, on the Mississippi Gulf Coast. Diane Goldstein is a 21-year veteran of policing who was the first female lieutenant for the Redondo Beach, California Police Department. She's a guest columnist for many media organizations and a subject matter expert on criminal justice and drug policy as the executive director of the Law Enforcement Action Partnership, or LEAP, which is a group of criminal justice professionals working to advance justice and public safety solutions. Jeff Riesinger, MD, is a general surgeon in private practice in Phoenix for more than 40 years. He's a senior fellow at the Cato Institute, where he works in health policy studies, focusing on harm reduction and the physical, mental, and societal harms caused by drug prohibition. Got his MD from New York Medical College and is a fellow of the American College of Surgeons, and also serves on the advisory council of the American Council on Science and Health. And then last but absolutely not least is Anthony Salandy, PhD, MSc. He's the Senior Director of Development and Business Strategy at National Harm Reduction Coalition. Dr. Salandy is a fierce advocate and researcher of health equity and social justice issues, former American Association for the Advancement of Science, Legislative and Executive Branch Policy Fellow in the U.S. Congress and at NIH and IDA. That's our folks. Super excited to hear from them. I'm just going to set us up a little bit and posit a broad definition of harm reduction, and you four can grade my paper. So at its core, harm reduction is pragmatic, non-judgmental, compassionate approach to individual behaviors that carry a degree of risk. So what we're going to be talking about today, it acknowledges personal autonomy, dignity, and worth. So the idea may be radical that people have the right to make decisions for themselves, and that no matter what behaviors people engage in, their lives matter. It also acknowledges that everyone engages in some risky behaviors, and not everyone can or will be completely abstinent from behaviors like taking drugs, smoking cigarettes, and more. But with good information and tools, people can make choices that mitigate those risks. Okay, so as you've heard, our panelists today have deep experience in this space. I'm excited to stop talking now so we can hear from them about the state of integrated harm reduction today. So first up, let's talk about banning things. I'd like to ask you all what we have learned over time about the impacts of policies that enact prohibition on behaviors, substances, whatever, or require abstinence across those behaviors. Let's go, Dr. Singer. Jeff, what do you think?
Well, I think when it comes to the prohibited drugs that we have today, a great deal of the harm that we see from people using drugs obtained on the black market is a direct result of prohibition. So many of these drugs actually, if they were used, if the users knew that of their purity, their dosage, that it was what they were purchasing, and they were able to have good information on how to use them safely, many of these drugs are actually safer than some drugs that are legal. For example, alcohol. Alcohol can cause a lot of harm, cirrhosis, cardiomyopathy, dementia, and cancers, all sorts of problems, bleeding. And of course, it's legal and most people use it safely, and we practice harm reduction right down to, for example, when we have a designated driver, if we're expecting that we're going to be drinking a little too much at a social gathering. That's all forms of harm reduction. So a lot of the overdose deaths we're encountering right now, I would argue most of them are the result of the fact that we have drug prohibition and people are obtaining drugs they want to use through underground means where they can't be sure of their purity, their dosage, or even if they are what the person who sold it to them says they are.
Right, right. Am I right that our drug supply in the US is more toxic than it's ever been, despite how many decades of the war on drugs? Anthony Salandy, let's hear what you think about this.
Yeah, I think there's a litany of results of a failed war on drug policy that's been implemented for decades. There's been an increase in crime and violence. Criminal organizations take advantage of higher profits associated with drug smuggling and distribution, resulting in more violence. We have an overcrowded prison system, a sort of a blossoming in a bad term, the prison industrial complex, where 1 in 5 incarcerated people today are locked up because of drug offenses. Even in the state of New Jersey, where I live, 59% of the prison population is made up by Black folks, and majority Black men. And a lot of them are in there locked up for minor drug offenses. Stigmatization and marginalization, right? That creates barriers on access to care and treatment and prevention services. There is a recognition by the federal government in language on how language can stigmatize and marginalize people who use drugs. Therefore, in the current funding budget for the federal government, you see changes, the dropping of the use of the word abuse in SAMHSA, in NIDA, in NIAA, so NIAAA. And so those things is sort of like a reflection of or recognition that there is stigmatizing and marginalizing language. And also there's a public health risk. And we need to understand how prohibition has led to increases in certain areas in HIV and Hep C and other chronic diseases.
Thanks. Right. So let's jump over to Mississippi. And Angela, what do you think? What do you all see there about the impacts of prohibitions or the kind of expectation that people can or will be abstinent from, various behaviors?
We often at End It for Good talk about, use the example of alcohol prohibition in the 1920s and what a terrible disaster that was, and how it brought about all of these other unintended consequences because people were not ready to give up their use of alcohol at weddings and social events. And it's funny that, well, it's not funny. Down here in Mississippi, we still have that happening. There are still Mississippi was one of the last states to repeal alcohol prohibition, and it is still on a county by county basis. And we have counties in our state that are dry counties, we call them. They're not allowed to sell alcohol, and if you live there, you're not allowed to purchase it. And so we see in very real time what that can look like, because in those counties, you see higher concentration of other substances being used in those counties. And to move away from alcohol, we can look at another substance like kratom. There are counties here in Mississippi who, over the past few years, have kratom has come on their radar and they've cracked down on it. And then, there are other substances that are now coming and causing problems that are replacing the kratom. So it's just like whack-a-mole. And I think that will continue. It continues at the national level. So we crack down on ephedrine-based methamphetamine, and now you've got cheaper amphetamines like ice and so forth. You crack down on opioids. Now we have fentanyl. At the local, municipal, and county level, you crack down on kratom and you get tianeptine. So if that doesn't exemplify why prohibition is not going to work to stop people from acquiring the substances that they need to medicate themselves. I don't know a better way to explain it. So that's what it looks like here.
Oh, you're muted, Jeff. There you go.
If I could just say, there's an interesting report in Reason magazine online, reason.com, came out yesterday afternoon by Jacob Sullum. Apparently, there's been a surge of methanol-related deaths in Iran. And Iran has alcohol prohibition for religious reasons. And particularly with the pandemic, as has happened worldwide, there's been an increase in alcohol drinking. And there are people who want to drink alcohol in Iran, and they've been buying it on the black market. There's also been a shortage of ethanol because a lot of it was kind of diverted to create things like hand sanitizer because of the pandemic concerns.
Mhm.
So the bootleggers have been putting methanol as a substitute, just like fentanyl was added to heroin,
Right.
and Trank is being added to fentanyl. So there's been a rash of deaths from drinking alcohol. And that happened in the United States during alcohol prohibition. In fact, the federal government actually ordered methanol to be put in industrial ethanol, so that if people tried to drink diverted ethanol, they would be punished with death. Now, of course, that was cruel and sadistic. But in any case, these are just examples. It shouldn't, the harmful effects of prohibition don't just apply to the commonly known prohibited drugs in the United States. It's we see this with when kids were buying prohibited vaping equipment that had THC in it, was mixed with vitamin E acetate and caused lung damage. This is what happens when you create a black market.
What was fascinating too with those those lung injuries, which I think still to this day, the myth persists that came from vaping nicotine, but in fact, 90-something% of those lung injuries have been definitively attributed to what you're saying, Jeff, to people hacking their vapes essentially and adding THC that had an additive that was harmful. But those lung injury rates were lower in states where cannabis is legal because the temptation to whatever, external avenue was not as needed because you had a legal and regulated substance that was less likely to have, unsafe ingredients in it.
In fact, the regulators in the state of Washington, when they learned that that vitamin E acetate was harmful to the lungs, they required that any cannabis shops that were selling, vaping cartridges with THC in it not use vitamin E acetate. That's what happens when you have a legal and regulated market.
So speaking of laws and regulations, Diane, love to hear the law enforcement perspective on all of this from you.
It's philosophically, let me start, because everyone's gone back to alcohol prohibition. And I think this is really important to say. In law enforcement, the chief that professionalized law enforcement in the United States was Chief August Vollmer back in the 20s and 30s, one of the first presidents of the International Association of Chiefs of Police. And I have a really interesting paper where it was an analysis of what his philosophy was relative to issues of should law enforcement be investigating moralistic crimes or crimes that are linked or tied into public health interventions. And what Vollmer said in the 1920s and 30s was that prohibition fueled death, disease, addiction, law enforcement corruption, engendered disrespect between the communities that they served. And he was very clear, even back then. He talked about it in, very stigmatizing terms back then. But he said that the government, especially around the issues of opioids and substance use disorder related to drugs, should provide people who were suffering from an addiction at taxpayer costs a safe supply of drugs, right, in order to save people's lives. And then he clearly said that law enforcement will never be able to solve a public health problem. And he was very clear that law enforcement should not be investigating sex work, bans like alcohol or drugs. And I think that law enforcement in particular deliberately chooses to ignore it or doesn't know about it. And so all our drug policies, all our law enforcement policies have been segmented from other things that are much more efficacious in the prevention and treatment of public health interventions. Look at what we've done with tobacco and nicotine. We are at the lowest smoking rate in the country. Our kids continue to use less drugs, have less sex, use less alcohol. You know, so I tend to look at this as the kids are all right. So why are we now thinking about the next, war on drugs is a war on nicotine? Look at the issue of what the FDA is proposing by targeting Black communities to ban menthol cigarettes, right? And all its impact. And what we're seeing is this experiment at the state by state level is starting to show failures. We recently had Massachusetts bill introduced to repeal the ban because Massachusetts banning menthol 3 years ago, I think is now, has been such an abject failure that legislators are finally saying, oh, this isn't working. So why are we continuing to engage in the same failed strategies that we know, again, as Vollmer said, increase death, disease, addiction, and violence? I really believe that the criminal justice system needs to stay out of public health interventions, leave those to people who know how to treat this. And the last thing is, I think it's really important, both for law enforcement, for the general community, we have to stop looking at drugs as good drug, bad drug. I'm wearing a t-shirt that I picked up a few years ago that says, nice people take drugs. You know what? Every day I am a drug user. I'm a proud drug user. I use it. Here's my cup of coffee that I do not wake up. We have got to start acknowledging that what we need to focus our very harmful criminal justice interventions on is people who do harm to other people, people that potentially need to be held accountable in that fashion. But we have to start looking at this from a public health perspective, and cops and the criminal justice system are never going to be able to fix this issue. We don't have the skills or the equipment or the necessary interventions.
Right. So on that note, let's hear some good news. What are the biggest recent kind of popcorn style recent successes in harm reduction in public policy? This can be state, it can be federal, it can be substances that are currently legal, currently illegal, it can be behaviors that are, across the board. What's working?
Well,
Where are we
obviously,
seeing achievement? Yeah.
the first obvious one is that Narcan has been made much more readily available. Naloxone, the overdose antidote, naloxone. Sadly, there are still pockets of people who think that making naloxone available to opioid users, quote unquote, only enables them to engage in this evil habit. But more and more lawmakers, policymakers, and the general public has said, this is a lifesaver. And the FDA recently, finally, after years of foot dragging, has begun to make naloxone an over-the-counter drug rather than requiring a prescription. So that's one big advance. Also, we're seeing that, we did a study on this at the Cato Institute, and in the late 1970s, the Drug Enforcement Administration tried to push the various states to enact drug paraphernalia laws, which make it illegal to possess, sell, or use whatever they listed in their laws as drug paraphernalia. And every state except Alaska enacted them. So Alaska is the only state in this country that doesn't have drug paraphernalia laws. Well, in most states, those drug paraphernalia laws included anything used to test illicit drugs. Many states now have amended their laws to allow fentanyl test strips. I mean, it's sad that if you give a fentanyl test strip to a teenager who just bought oxycodone on Snapchat so that the teenager could test it to see if it's really oxycodone or is it counterfeit and it's fentanyl, you can get arrested in some states for doing that. So now finally, the majority of states have modified their drug paraphernalia laws to allow for fentanyl test strips. But now we're having this new threat of xylazine, the veterinary tranquilizer, or tranq, being mixed with fentanyl. And fortunately, there were test strips for that. So now those states have to go back and say, and also test strips for that. It'd be much easier just to say, test anything used to test illicit drugs is no longer considered paraphernalia in our state, as they did in the state of Minnesota recently. In fact, Minnesota repealed its paraphernalia laws. So
I haven't met a single person whose mind is not blown by this. When I say not the drug, the little strip to test the drug, so that, and you got to make it personal for people. Your college kid, you know, doesn't think they're taking a Percocet and it's actually fentanyl and it's one pill. And that's not the only reason to do it, but I think personalizing things helps people understand. And I've not met one single person whose mind isn't blown by the fact that I'm a person who's obsessed with Texas. Texas and a few other holdout states, which I just dropped in the article in the chat, still criminalize these test strips to help keep people alive.
Although the governor of Texas recently came out in favor of legalizing fentanyl test strips.
But it didn't pass. Didn't
right.
Died in the Senate.
And again, I would say just legalize testing equipment, not because there's if this panel knows the iron law of prohibition, which is the harder the law enforcement, the harder the drug. So there's always going to be a new thing coming down the pike. Now it's tranq is replacing, fentanyl. And then after that, there's going to be probably nitazines or ISO, as it's called. There's going to be always going to be something, and there's always going to be a way to test for it. So you don't want to have to go back to the legislature to get a new thing approved each time. Just say testing equipment's okay.
All right, Anthony, you're up.
Yeah. I think now there are a lot of policy wins recently, including FDA recently approving OTC Narcan. But I'm always the type of person that's saying follow the money, right? We've seen harm reduction mentioned in the State of the Union. We've seen harm reduction included in President Biden's drug policy. But when you take a look at the funding, we've seen CDC recently started a $60 million funding for SSPs. We've seen NIDA create a harm reduction research network. We've seen passage of the MAT Act. We've seen recently California a one-time funding of $61 million to allocate for general funds, from the general funds, for 4 years to sustain and expand California Harm Reduction Initiative. In schools, we've seen Superintendent Alberto Cavallo allowing students in the LA Unified School District carry Narcan. We've seen in Arlington, Virginia, that like secondary school teachers are required to take naloxone training. So we are seeing all across the U.S. in states where their states are requiring first responders to get trained. And I guess the biggest thing within the last 2.5 years is the opening of 2 overdose prevention sites in New York City, one in East Harlem and one in Washington Heights. And they have reported like heavy usage of their services. And the early data suggests that supervised consumption sites in these settings are associated with decreased overdose risk. And so there are a lot of wins, a lot of policy wins, but we still have a long way to go. There are some states who do not allow syringe service programs. There are some states who don't have Good Samaritan laws. And so we still have to push at the local level as well as the federal level to get some of these changes.
Thank you. Angela, what are you seeing in the state, in Mississippi or other states that you think look good? You're muted. Thanks.
I'm encouraged by all the things that Dr. Singer and Anthony have just listed. Those are huge monumental wins. You see funding coming for harm reduction programs, and you see states making legislative action to back that up. I think we here in Mississippi just recently helped pass fentanyl testing strips and or make them legal here. I am really encouraged about seeing the conversations about harm reduction begin to happen in criminal justice spaces. So while that terminology and that the push to bring harm reduction to the forefront of the way we are responding through treatment, like through CDC and SAMHSA and all those agencies, I am encouraged to hear conversations about harm reduction happening in the Bureau of Justice offices and the drug court spaces. So last summer, I was invited to sit on a panel discussion at the National Association of Drug Court Professionals conference in Nashville, and their COO and another judge from New Hampshire and I discussed what does harm reduction mean, to just introduce that topic to an audience of criminal justice professionals who probably the majority of them had never even heard of it, and if they had, they did not have a good opinion about what it meant. I think many of them would fall into the category of they chalk that up as enabling, but we were able to have like a great dialogue about what harm reduction means and what it means in their spaces. And then I was even more encouraged a year later when we were invited back to be part of a roundtable discussion to say, okay, so what does this look like inside of our drug court programs, and how can we bring that into the way our programs are operating? So the criminal justice system has long been the hammer by which our society punishes people who use substances. And so to hear harm reduction moving into those spaces is very encouraging to me.
So, it's interesting because I know I have my cue on the last one here. I want to talk about kind of like the global and Anthony, I think you can probably validate this because I know you guys do a ton of work at the UN. I was at the Commission for Narcotics Drugs this year at the UN, and so important on that the language that's being used by multiple countries globally includes harm reduction, decriminalization, respect for people's dignity, civil rights, and how harmful the drug war is at a global level. That's been a significant change and is very positive and has been pushed by NGOs on the ground in the UN. So from a law enforcement perspective, I started in this work in advocacy after my brother passed from a polydrug overdose in 2000. He died in 2007. I became a LEAP speaker in 2010. We have seen the expansion of law enforcement, criminal justice professionals across the board who basically publicly acknowledge the harms and the failures of the drug war and have embraced harm reduction interventions. I think the other thing that's really critically important, because of money and research being funded as a specific research project, one of our police chiefs, Chief Brandon Del Pozo, is also a drug researcher for National Institutions of Health. And he and I think 5 others just co-authored an amazing piece of empirical research that validates everything that is being said here. Is that they analyzed 2 years worth of drug disruption markets and data in the state of Indiana that has incredibly regressive drug laws. And they tied those drug disruptions in the market to 7-day, 14-day, and 21-day analysis to see if there was any harms associated. And what you saw very clearly is there was an increase in fatal drug overdoses, 7 days, 14 days, and 21 days. And so organizations are looking at that, law enforcement, saying, okay, if we have to do these types of enforcement actions, how do we also either before, during, or after the fact excuse me, make certain that harm reduction and other organizations who are working at the grassroots level, meeting people who use drugs and saying, hey, this just happened. You need to be more careful. And so, I think there's a lot of positive changes. There's also challenges that we have to recognize. And this fentanyl overdose challenge is both law enforcement and legislators, state, local, and federal level, just feel like they have to do something. And the only thing they know how to do is push regressive prohibition policies because they don't know what to do. So we've
It's
made
the
tons of
easier
progress
thing.
in saving people's lives. And it's the work of harm reduction organizations, and coalition building that is going to continue to save people's lives by ensuring that voices of people who use drugs are heard at every level.
Diane, I appreciate the words and the compliment that we work at the UN. I would love for us to do a lot more work at the UN. But one of the things, to me, I think the focus needs to shift, right? It's not the responsibility of the harm reduction community to engage policymakers, right? So, it's like, I think that how policymakers need to realize if they're going to make an informed decision about policy, about funding, that people who use drugs, people from the harm reduction community need to be at the table and be incorporated into the decision-making process, right? Or else what you get is this top-down, even in research, this top-down policy that sometimes doesn't make sense, these funding priorities that oftentimes do not hit the mark and oftentimes don't really. So for example, SAMHSA, and I'm not going to rag on SAMHSA, but SAMHSA had a funding initiative for harm reduction, and little of the money actually went to local harm reduction organizations. And so without that sort of, if I'm going to partner with you, I want a true partnership, and that means bringing you in, and not us waving our hands and saying, yeah, we're here, listen to our voices so we can be heard. No, we don't. It's less about being heard, but being part of the decision making.
Completely agree, Anthony. And I was just at a public health and public safety retreat. And one of the people that was brought in was a justice impacted individual that is now a peer-to-peer supporter working with law enforcement to save people's lives. And that was exactly as we have to have, if we're going to continue to have the policy discussions, we need to change it to talk about community health and safety, which is much more inclusive, and every stakeholder needs to be at the table, especially people who use drugs. And that's what my brother's overdose death taught me.
I'd like to just add one more thing to the mix here. An area where we need to make progress, there's a slight beginning to it, is a United States allowing the states to allow overdose prevention centers. They used to be called safe consumption sites, but overdose prevention centers is actually a much better descriptor. We did a study that came out in February for the Cato Institute about this. Based upon our research, there are 147 sanctioned, that's government sanctioned overdose prevention centers in the world, in 16 developed countries, including 2 in the United States, both in New York City. The problem is that, and by the way, they've been around since 1986. The first one was in Switzerland in 1986. There are 14 in Switzerland, 25 in Germany, 38 in Canada, and there's even one in Mexico. But we have a law in the books called the Crack House Statute with 21 USC section 856 that was passed in the 1980s that makes it illegal for you to knowingly allow someone to use an illicit substance on your premises. And that's what's standing in the way of harm reduction organizations opening up overdose prevention centers in the United States. The mayor of New York in November, the end of November 2021, basically defied the federal government and authorized 2 of them. And we had a conference on this, and the director, Kaylin C., who set that up, was on our conference in March. And she reported that after its first year, they had already reversed 750 overdoses. That's 750 people who likely would have been dead had they not been around, and they've engaged well with the community. In fact, one of them is across the street from a daycare center, so that they know how to interact with the community. But it's just prosecutorial discretion that allows those two centers to continue. The state of Rhode Island legislature passed a law allowing for overdose prevention centers to get established, and there's one that's about to come online, and then Minnesota recently did. But the fact is that they're having to defy federal law, and it's just and everybody's relying on prosecutorial discretion. I think Congress needs to repeal the crack house statute, or if they can't repeal it, if that's not politically feasible, then at least amend it to allow overdose prevention centers that have been sanctioned by their state, county, or municipal health departments to operate, because there are loads and loads of people out there who would like to help their members of their community with overdose prevention centers. So that's an area where what I'm hoping is, just like with marijuana, as more and more states and cities just authorize it in defiance of the federal government, that kind of so-called civil disobedience will pressure Congress to act eventually.
So, right, thank you. I'm trying to drop as many feverishly links into the chat for attendees so you can see studies. I found your Cato study, Jeff, and doing some acronym demystifying and what have you over there. So let's do a brief, because we are running a little bit behind, as I kind of expected, because you all are such wealths of information. But can we talk about the intersections? We talk about at Safer from Harm and at our street about integrated harm reduction, about thinking across behaviors, across substances. Could you, kind of name check some communities that are disproportionately impacted by the confluence of issues and topics that could really benefit from a harm reduction approach? So, like, I'll share an example that I personally am passionate about. Was reading a 2015 peer-reviewed study the other day on veterans that found that smoking cigarettes increased veterans' odds of opioid misuse, for example. So these are not issues that exist in silos. They exist in people's lives in the real world. And there are populations and subgroups that, in our country that are disproportionately kind of, I think, crying out for us to take a harm reduction approach. So I would love to hear from you all, where you're seeing that.
Yeah,
I'm going to just briefly throw out tobacco harm reduction and the Black community and the fight right now on the menthol ban. I think all of us here can agree tobacco smoking is harmful. But what the FDA is looking at relative to the menthol ban, we know they targeted the Black community. That happened, a long time ago. We need to ensure that people who smoke tobacco are not treated disproportionately. And what we know with the menthol ban and what concerns our organization is you're already and have been seeing significant events on the street that have resulted in excessive use of force because the initial contact was about tobacco. We have vaping incidents in Central Park recently. You have Ocean City, Maryland. You've had multiple incidents that I can talk about, and we don't have time. And so we need to really have this very nuanced conversation and say, what's worse? Banning tobacco is not going to ensure that people stop smoking.
I just like to add about menthol cigarettes. Not only does it disproportionately target the Black and brown community, where menthol cigarettes seem to be more popular, but it actually, there's some, and I blogged about this, there's some recent scientific evidence that menthol cigarettes actually might, in a way, be safer than regular cigarettes, because the evidence is that people who smoke menthol cigarettes tend to consume fewer cigarettes in a given 24-hour period. I'm not a smoker, but I could only assume maybe it's you get satiety from the menthol flavoring. And because of that, there seems to be a slightly lower incidence of the development of lung cancer. So not only are you targeting a community that happens to prefer that flavor of tobacco, but you're actually maybe taking away a harm reduction, something that's unintentionally less harmful than what you're asking them to substitute for. Because the evidence is that when people can't get menthol cigarettes, they just move to regular.
I'm going to jump in. Anthony's talking.
Go ahead, Angela. While Anthony comes off mute, let's hear what you have to say, and then we can jump to Anthony if that's all right.
Well, Jessica, you know my stories about harm reduction and cigarettes, and I think I would not be in favor of any form of further regulation or banning or prohibition on cigarettes or menthol. Former smoker, preferred menthol cigarettes, but I don't know about what Dr. Singer was saying about whether they are less likely to cause cancer. I sure hope so. But I do have a candid story that I think can fit in well here. I had a dear friend who was a mentor in recovery and also ran a women and children's treatment center in North Mississippi. And it was the first and really the only for a very long time treatment center in our state where pregnant women could go and receive treatment and stay there until they had their child, and then they could even stay for up to a year afterwards. And several years back, our state's Department of Mental Health, actually, I think it might have been a multi-state agency effort to ban ban tobacco at all state-funded facilities. So at this treatment center, they were saying, if a client comes in, because you receive state funding, they are not allowed to smoke cigarettes. And Shane Gerard, who was the director of that treatment center at the time, pushed back really hard on that. He said, you mean to tell me that these women who have been using really potent substances, contaminated heroin or methamphetamine or cocaine, and we're asking them to stop that and come here and like they can't have cigarettes? That you have to weigh the options here. So you're going to tell me that this pregnant woman is going to have to walk out the door because she can't smoke a cigarette, and she's going to go back to using these more harmful substances. So he pushed back and actually changed that policy so that more clients would not leave.
I remember when you told me that story, and it was like, right, this is the pragmatism of harm reduction, is you basically have two choices in that situation. You've got folks safer and in treatment and smoking if they smoke, because they're not going to stop today or maybe ever. Or you have folks not getting treatment and smoking. Those are really pragmatically the only two short-term options, medium-term options for that population. And that was like such an illustrative point for me.
I can't.
Right. Yes.
Sorry, go ahead.
No, please.
Quickly, I cannot tell you how many phone calls I've answered where I'm trying to help a friend or help a parent get their kid into treatment somewhere, and the question is, can I smoke there? Because they know there's the substances that they've been using are going to be taken away, withdrawals coming, all of that stuff is coming. And if you can't smoke, then I'm not going. So literally people are like staying on the streets because they couldn't go somewhere because tobacco was prohibited. And that just does not make sense at all.
Anthony, I know you were coming off mute a second ago, so let's hear you.
So these intersections and interplays with harm reduction, we see it in supportive housing, right? Where these archaic rules, as Millette said, these archaic rules that prohibit you from going into or attaining supportive housing if you use substances or drink alcohol. I would say any medical or mental health entry points. So for example, the emergency department, right? The horror stories of people who use drugs going into emergency department for either treatment of like pneumonia or soft tissue infections or chronic conditions, and not getting the services they need because of biased, judgmental care that's being provided. And there are things that's being done. There are trainings that NHRC does with emergency department staff to train them on how to provide services for people who use drugs. And it's across the board. Reproductive health, pregnant women do drugs, right? And so how does harm reduction principles and practices help support them in their journey? right? And we can talk about women who are in preconception stage, right? Sex work, right? Standing laws, sex workers being arrested just for standing around. Those types of things, the LGBTQIA rights. And one of the big things that I'm on recently is the lack of access to affordable medical insurance for people who use drugs, right? That is something that needs to be dealt with and needs to be addressed at the federal level.
I am listening to the audiobook of Dope Sick right now, and I'm in the chapter about who gets to go, whose kids get into treatment and who doesn't because of health insurance. And it is heartbreaking to listen to. Maybe everyone, all of our attendees have read or listened to it, but could not recommend a listen more.
Yeah, and I would recommend when you finish that you next move to Raising Lazarus.
It's on my, yep.
Yeah, Raising Lazarus is the next. Okay, so we had the opioid lawsuits, now what? And it is all about harm reduction, and it's beautiful.
I'd like to just say something about insistence on abstinence, because I don't think that, not only, of course, is it unrealistic when, for example, Housing First insists that people be abstinent, and that's going to make a lot of people not take up the housing that's offered them. But a lot of people don't understand, a lot of policymakers don't understand that the definition of addiction is compulsive use despite negative consequences. Negative consequences include going to prison, include living on the street. I mean, that's the difference between an addiction and, let's say, just a physical dependency. So when you insist on abstinence, then you're really not being realistic. That's very hard. Addiction is a compulsive behavioral disorder, and you're asking an awful lot of a person for them to abstain. Now, some can do it, and these abstinence programs like 12 steps, they work about 8% of the time. But harm reduction is saying, I'm not asking you to be abstinent. I'm doing what I can to make what you're doing less dangerous. I'm being realistic. So that's number one. I think we need to get away from this insistence on abstinence, including in housing. And abstinence doesn't just mean abstinence from illicit drugs. It means abstinence from tobacco or alcohol or whatever else is that you like to engage in. Second, I think a word needs to be said in favor of drug use. The reason why humans have been using psychoactive drugs since the beginning of recorded history, and the reason why a lot of humans understand that they can get cancer or heart disease from smoking tobacco, but choose to do so anyway, is because obviously they derive some pleasure or benefit from it, even if it's a self-medication benefit in the case of some of these drugs. So just to start off with the assumption that everybody needs to not do these drugs, I think is also unrealistic. Some people are willing to accept the risk, and our job as policy analysts and policymakers is to do what we can to mitigate the risks they're taking. But for some people say, I'm willing to risk getting lung cancer. The pleasure I'm getting from smoking at the end of a day, the stress relief or whatever, is worth me taking that risk. And that's a personal decision.
But speaking of, if you could offer folks that same experience at a much lower risk, some might take that, and that we would consider to be good.
Well, unless we're
see,
moralizing, right?
Yes,
Unless we're moralizing
yes.
and saying it's just bad to do that, period. I don't want to make it less risky for you because I don't want you to do it, which unfortunately is an attitude that many people in the policy world have.
Right. All right. I'm looking at the time, folks. I got one of two questions. Pick question one we've touched on a bit, which is like, what's stopping us? And I think, you know what, we're going to go past that. We've talked about this, moralizing, and I'm curious what's stopping us from taking this integrated approach across substances, across behavior, stop this abstinence only mindset, which clearly does not play out in real life. And so what do we need to change then in the public narrative and in our policy to get us to that place?
As a doctor, I think, and I use this example a lot when I'm speaking to general audiences, harm reduction is much of what we do every day in developed societies like the United States. I mean, when we have patients who are developing complications of their lifestyle choices, like they're getting heart disease, high blood pressure, diabetes. And we know if we can only get them to change their diet and maybe go on a certain exercise regimen and the like, then we probably don't even have to put them on any medications. But we realize that they're just, for whatever reason, they're not able to follow what we think they should follow. This is what we do every day when we prescribe a statin drug for cholesterol or a blood pressure pill or something like metformin for diabetes. We're basically saying, I'm not endorsing your choices. I'm doing what I can as a healthcare practitioner to make your choices less risky. So I think that's a good example to use in the general public, because basically that's an attitude that should pervade all aspects of human activity, not just, the patient-doctor relationship.
Any other thoughts on that? Or I'm going to throw a final extra question just for fun. We've only got, I think, 1 or 2 questions in the Q&A. So, like what do we need beyond harm reduction? Harm reduction, I think, should be everywhere, but it is not everything. So like what holistically, if we were doing everything right in harm reduction, in our policy, in our funding, in our laws, in our criminal justice approaches, what else needs to be out there in the world to complement that? To help people in their journey, to give them access to what they need?
I would offer 2 things there. I would say that just a clear understanding from all the professions that work on this issue, whether you're a medical professional, where you're in the justice space, you're in the treatment space, or even, in the educating space. If everyone can wrap their heads around that mental health, emotional struggle, emotional healing, your recovery journey, every single individual has an individual recovery journey, just like they have individual hurts and individual physiology that needs to be treated. I think our society has looked for broad strokes, blanketing solutions, and that is not going to work. It works for a slim few, but it is, if we can wrap our heads around the individualized recovery and journeys for people, I think that would help. I would also just echo Diane again and say that it is really, really important that people with lived experiences are at these tables all across the board, period. Whether you're working on Narcan legislation or you're working on what a aftercare program needs to look like for someone discharging from treatment or someone exiting incarceration. People who've been through those things have extremely valuable input to give. And so for all of us as professionals working in this space, if we can make it our responsibility to open doors for people with lived experience to come and be part of these conversations that we are lucky enough to have, I think that is one of the greatest services that we can do.
Yeah, I would add, and I echo Millette's about harm reductionists people who use drugs need to be at the table making decisions, not just on policy, but funding options. Research is really important. NHRC has a collaboration with the American Institute for Research in creating people with lived and living experience research board, where we meet with individuals and train people at the front lines on how to do research, how to capture data, how to report data, how to analyze data. But most important, I think that, as important, SAMHSA has a document for public comment right now on harm reduction pillars, practices, and values and responsibilities. And it's for public comment right now. I encourage everyone on this webinar to actually go online, look at the document. It's very thorough. There are a number of people who worked on that document. And I think it would not only guide SAMHSA's upcoming strategic plan, but also other federal agencies and how they think about harm reduction and incorporating it into their programs. And last but not least, I want to say that how racial equity and justice, language justice, needs to be a centerpiece of harm reduction practices, policies, pillar. It is a principle. But we need to focus on that because Black and brown folks are too often getting incarcerated for simple, using drugs or having residue in a syringe or something like that. But we need to understand the centrality of racial and equity justice in everything that we do.
Thank you, Anthony.
I'm just going to plus one what Anthony said relative to this issue. And, as we continue to move forward, I think legislation and educating legislators is so critically important. Individual stories of people with lived experience needs to be heard, but I also think that we need to also emphasize trauma-informed practices across every single system and level and really decide who's a first responder. I have this philosophical discussion all the time is, law enforcement is not the first responder to a drug overdose. Friends, family, loved ones are first responders. We need to ensure that legislators in particular understand that how harmful when you pass a law, no matter how benign, you're granting me as a police officer the right and the discretion to use violence to enforce that law. And that includes killing people, executing people. I will remind people, George Floyd basically used counterfeit money to try to purchase cigarettes. Kevin Gardner, cigarette related, is why are we waiting to not hold legislators accountable for their lawmaking? And they need to understand, and I stun legislators and their staffers all their time by saying this, a law, no matter how benign it is, you realize you can get people killed. And is that the best use of law enforcement resources? I would suggest it's not. And in fact, there's a growing swell, especially around the issue of tobacco and these tobacco bans, that I'm working with tons of law enforcement who says, we don't want to do this. Why are you doing this to us? FDA didn't even engage with law enforcement to talk about unintended consequences. And one of the things that we're talking about is, good people make bad policy without the people on the ground who can tell them this is how it's going to look like.
Maybe this would be a good note to close on. I think it's important for everybody to remember the ultimate form of harm reduction is to end prohibition. At the end of the day, we should stop prohibiting additional substances as we seem to be in the process of trying to do when it comes to tobacco and e-cigarettes. Don't prohibit anything else and unprohibit everything that you prohibited, because once you get rid of prohibition, then it allows it not only makes whatever the substance is more safe because you could know what it is, it's legal and regulated, but also allows the rest of us to engage in harm reduction without fear of reprisal and without having obstructions in the way. So that's the ultimate goal, should be to end prohibitions of substances. When you're talking about people engaging in victimless crimes, they're using substances or doing things that primarily affect them and no one else's rights.
Any last words? I fear we may not get to Q&A, although attendees, can I just give you 10 thumbs up for hanging in there for the whole hour and beyond? So if you hang in, and if any of our panelists have a few extra minutes, love to get to it. There's just a couple questions, but before we do that, wonder if we've got any other parting thoughts. And attendees, please do check out the chat. I've been dropping frantically resources in there, and also websites for our panelists so that you can learn a bit more about their work if you're not already familiar. Any other parting thoughts from y'all? Otherwise, we'll jump to Q&A. We got a couple questions here. One very specific, asking some harm reduction orgs have strong opinions about higher doses of naloxone, such as the 8 milligram. This is very specific, intranasal naloxone. What are your thoughts about that, or about making all forms of naloxone available?
I think all forms of naloxone should be available. Right now, it's only the nasal spray. The injectable isn't. The injectable is much less expensive. A harm reduction organization that I work with here in Arizona still collects the injectable form, and I've actually volunteered to be the physician giving the standing order so that they can get it, because in our state, the standing order is the workaround from the prescription requirement by the FDA. And when I asked the director of the harm reduction organization, why do you need me to give a standing order? You can get this stuff over the counter now. She told me, well, the injectable is much less expensive. And, people could use over the counter injectables all the time. People know how to use injectables. So I think it should be over the counter. I don't have any specific comments regarding particular doses. I think it's, obviously you use the dose to get the job done.
I read that question earlier and wanted to share a few thoughts. So in Mississippi, syringes are paraphernalia. So an injectable naloxone option is not available here. Only the nasal spray, which is probably about 4 times more costly than the injectable kind. The question, though, regarding higher dosages, I just read in the OSNN email threads recently a email that was written by a emergency room nurse who has worked in ERs for a number of years, and it is just pretty standard there that they push for all overdoses. They push 2 milligrams ready, 2 milligrams for overdoses that come in. Well, she also simultaneously took on a part-time job and was working in a harm reduction center where they are pushing naloxone to help revive overdoses, and they only use 0.8 milligrams. They resuscitate people, or I'm not sure if that's the right word. I'm not a medical person. They reverse the overdose and the person comes back in a much more stable state. They are not pushed all the way into withdrawals. So if anyone doesn't know, when you give someone naloxone, yes, it will reverse the overdose, but it will also put you into a state of withdrawal. And so they are actually emergency rooms that are pushing 2 milligrams or pushing 4 milligrams or giving a full dose of a Narcan nasal spray. Like, of course, that person is waking up in pain or waking up distressed. So I think the conversation around from harm reduction, pushing back against these higher dosages of naloxone is because they're really harmful and they're not necessary. And so whoever asked that question, if you wanted to drop your name in, I'd be happy to send you this email that the nurse gave. It's her firsthand account of saying, I'm not doing this anymore.
But from a practical standpoint, when you're dealing with first responders or even, friends or loved ones, with the potency of some of the fentanyl analogs that people are getting through the black market, sometimes it's just more practical to give a bigger dose because you're concerned about saving a life. So your point is well taken, but I'm just saying, sometimes you can't have that kind of nuance when you're dealing in an emergency situation, out in the street or in the field or in your house or something like that.
I just wanted to add I'm going to put it in the chat, that CDC has 4 harm reduction technical assistance centers, and National Harm Reduction Coalition is one, NASDAD, University of Washington, and there I put the link in the chat. If you have any questions around harm reduction, and about your organization, your syringe service program, you can actually drop a request in there, and the TA centers will receive it, we triage it, and then we respond to it.
Oh, we can't hear you, Jessica.
Muted. Sorry. We do have a couple other questions in here. If folks are willing to hang in, great panelists. I know you've got to, go do your important work. So whoever's got to drop off, got to drop off. I'm just going to ask I'm going to mash two questions together that I see in our Q&A, and that might be it. We've got a couple questions related to the World Health Organization. So more global picture is, but both about the tone that the World Health Organization is setting on tobacco and nicotine policies. For example, the Director General of the World Health Organization recently said that e-cigarettes are, quote, a trap to recruit children and not harm reduction, end quote. So how does that reconcile with what the US is doing versus, say, the UK, New Zealand, around the world, and who and how can engage with bodies like that?
I'm going to have to get off because I
Yes.
have to go to my clinic, but I just like to say that is completely against what the findings of what the evidence shows, of course. I mean, it's well established that nicotine e-cigarettes are an excellent form of excellent form of tobacco harm reduction. It helps people quit smoking. There's evidence of course, it's most places make it illegal for under the age of 21 to obtain it, but the evidence is that where teens are using e-cigarettes, were they not using e-cigarettes, they would have been using tobacco obtained illegally as well. And both teen smoking and e-cigarette smoking by teens is at a record low. So I just think that they should be embarrassed for that non-scientific statement. And with that, I'm going to have to leave. Thank you very much.
Mic drop from
Thanks,
the
Dr.
Thank
Singer.
you,
Bye,
Dr. Singer.
Singer.
Bye-bye.
Let me say this. I started my law enforcement career in 1983, and I am so exhausted from having to answer what about the children, right? Is the what about the children argument is rhetorical and ideological, because every day as a parent, and even today with my son being 32 years old, I practice harm reduction in my parenting. We always need to reduce the risk to our children. And we've obviously done a good job because our kids are having less sex, less abortions, using less drugs. I'm not saying that the drugs issue is not harmful. What we have to be concerned is about saving our kids' lives. And I know too many parents who have lost their kids to fentanyl because they didn't talk to them about the dangers of prohibition and how it fuels death, disease, and addiction.
I've started talking to my kid.
About, sports locker rooms, people try this, try that, and just really honest conversations, as scary as it is as a parent. But, starting to work in harm reduction has helped me have better conversations with my kids, actually. Any other thoughts before we go? I know we're way over, so I'm going to, I think, release you all into the wild and back into your very important work. Incredibly grateful to all of you for taking your time, and to our, 27 attendees who have hung in 10 minutes over time. So y'all are the real stars here. Thank you so much. We know we have a lot more work to do, but really incredibly grateful. I know that video will be up, and I think we'll send that out to attendees who registered within a few days of this event. And so we'll be sharing that back out again, so y'all can share with other colleagues as well. So thank you all again. And we will be bringing Safer from Harm more virtual events like this to dive into individual topics and intersections. So I'm sure we'll be calling on you panelists again in the future. Thanks for all you do.
Thank you.
Guys. It was lovely to see you this morning.
Take care.